Good morning. Hey, thank you. Good morning, everyone, and welcome to the last grand rounds of January. And I'm the warm-up act this morning for Dr. Christina Thaler, who's going to give us a great grand rounds on adult congenital heart disease. Before we get rolling, I want to mention to you a research investigator-initiated research study titled Myocardial Perfusion and Contraction Assessed by Cardiac MRI in Acute and Recovery Takotsubo Syndrome. Ray Tooth Saxena is the principal investigator. I'm the co-investigator, and this is a collaboration with imaging under the direction of Joao, who's giving us guidance on this. Stephanie Ebnett is our nurse contact here at the foundation. This, as many of you know, the pathophysiology of the Takotsubo syndrome is unknown, despite all these years that we've studied it. And there's great interest in the microcirculation as being a culprit in the pathophysiology. And so now that Joao and John Lesser have brought this new software to the Heart Institute, that we're able to study absolute myocardial blood flow using cardiac MRI and gadolinium. And we propose to do that in a small number, 10 patients with Takotsubo syndrome. And this is a typical cardiac MRI of a patient with the apical ballooning form of this syndrome. And this is the same patient with a gadolinium injection showing the lighting up of the myocardium from which the perfusion map can be generated using this new software. And this will create a perfusion map, polar map, much like is used in nuclear cardiology world, and segmented into 16 segments with the missing of the apex. So we'd love to study this and see if what we find. We don't have any preconceived notions. So if you have any patients, we'd like to get them very early in the course of this because the circulation probably changes very early on. And just contact Ray too, myself, Stephanie Ebnett. We'll be looking for these and let you know how that goes. So I would like to now move on to the topic at hand. As you all know, we have an internationally acclaimed congenital heart program here at the Minneapolis Heart Institute, led by Kelly Hahn and John Lesser and Chuck Gornick. And this morning we have our third-year fellow, Christina Thaler, who's going to give us a great grand rounds on this. Christina is a product of the University of Minnesota MD PhD program. So if you have any questions on the Krebs cycle, I think you're the go-to person. And Christina did her residency here at Abbott and is now a third-year fellow with a strong interest in adult congenital heart disease, and will be pursuing that line of investigation at the University of Michigan here this summer in their adult congenital heart program. So, Christina, thank you very much and welcome.
Well, today I'll be talking about adult presentation of congenital heart disease. I have no conflicts of interest, and I'd like to acknowledge Dr. Hahn, who gave comments while I put together this talk. So first of all, what is adult congenital heart disease? It's structural heart disease present prior to birth, attributed to abnormal fetal development, but does not include heritable diseases such as Marfan syndrome, hypertrophic cardiomyopathy, or arrhythmogenic ventricular dysplasia. It's important to understand the classification of congenital heart disease because based on this classification, all recommendations for follow-up and management stem from these classifications. So first of all, it's based on anatomy, which is defined as simple, moderate, or great complexity, where simple could be a simple shunt lesion that doesn't have hemodynamic significance, to great complexity, which is typically your cyanotic heart disease. Additionally, it's defined by physiology, which is a simple A through D system, very similar to many of our other types of ways that we classify in cardiology, with A being absolutely no symptoms or physiological consequences, to stage D being class 4 New York Heart Association Class 4 symptoms, and severe end-stage consequences. If we look at the overall prevalence of congenital heart disease, it's an increasing area. So this shows the distribution of adults in the European Union. So the pediatric population is relatively flat, but where the growth is coming from is in adults. And that is increasing rapidly. To 2030, it's estimated that 80% of patients with congenital heart disease will be adults, and the age group of over 60 is also an increasing population. A lot of this is thought to be attributable to the success of pediatric surgery. And the US is estimated to have a very similar prevalence of adults and that population that's growing. If we actually try to look at who actually presents with their first presentation in adulthood, the data is very poor. And the only thing that I could find in the published literature is a Korean study at an academic medical center where they offered physical exams free of charge, but part of that, prior to deciding to do your physical exam, you were offered an elective echocardiogram. So they took that population of people who just got a screening echocardiogram and found 1% of those patients had congenital heart disease, with half of it coming from bicuspid aortic valves. However, there was a whole range of other types of lesions that they found, ranging from atrial septal defects of a relatively simple lesion to great complexity of a congenitally corrected transposition of the great arteries. And when we were putting together the talk, we actually have evidence of all of these conditions that have had an adult presentation here at Abbott Northwestern Hospital, but based on time, we'll only go through half of the different topics today. And so we'll review each of these different topics in terms of the presentation, the basic management of these patients, and the major complications that these patients undergo. So our first case is a 29-year-old woman with tachycardia. She was referred to cardiology during her second semester of pregnancy, and other than being tachycardic, she was relatively asymptomatic. She was noted to have a soft murmur, and so an echocardiogram was obtained, and this was notable for right ventricular enlargement. She had a cleft mitral valve. In addition, she was found to have shunting across the atrial septum, and it wasn't completely clear based on her echocardiogram of what type of atrial septal defect that she had at this point, although there was concern from a primum ASD. After pregnancy, she underwent a cardiac MRI that was notable for a 2.3 to 1 shunt, which is a significant shunt across the atrial septal defect with considered hemodynamically significant of a 1.5 and greater shunt. She had preserved a left and right ventricular function, but her right ventricular was enlarged, and she was noted still to have a very complex ASD that still could not be completely understood based on the cardiac MRI. So because of that, she then got a cardiac CT scan that really did show she had quite a complex atrial septal defect. So here you can see the inferior vena cava coming into the right atrium, and she had an inferior sinus venosus atrial septal defect that had been missed both on her echocardiogram and her cardiac MRI. She also had a secundum atrial septal defect. This inferior sinus venosus defect was quite large, which you can see both here and here, that almost extended into a primum atrial septal defect, where she also then had the cleft mitral valve here that's often associated with a primum atrial septal defect. In addition, especially was aided by three-dimensional imaging with our cardiac CT scan, she also had a coronary sinus atrial septal defect, which had also been missed on her prior imaging. And this is similar to other patients where we actually have had coronary sinus atrial septal defects and inferior sinus venosus sinus defects that have been missed, and unfortunately were missed prior to going to surgery and only diagnosed after surgery. So for patients where you have any clinical suspicion, it's important to make sure to look for these either on your echocardiogram very closely or getting further imaging where cardiac CT scan will give you that data. So if we think about the types of atrial septal defects, she really had examples of almost everything except for a superior sinus venosus atrial septal defect. The important thing to remember is that a secundum atrial septal defect is the only type that can be closed percutaneously, which is preferred if possible, but you have to have enough rim tissue in order to close this type of atrial septal defect percutaneously. All other types of atrial septal defects would have to be closed surgically, as in our patient. So because of the complexity of atrial septal defect and the size of it, she underwent a right heart catheterization to ensure that she didn't have evidence of pulmonary hypertension, which she did not. And she had normal right and left-sided filling pressures. And you can see here that she also had normal RV function based on her catheterization. So if we think about who should get an atrial septal defect closure, the data is based on a secundum ASD, but the same thought process is often used for other types of atrial septal defects. So the important thing for her is that she had a left to right shunt, and then you look at the hemodynamic assessment. And it's important that they have a pulmonary vascular resistance less than 1/3 systemic and a PA systolic pressure less than 50% of systemic. If you have additionally evidence of right heart enlargement and a physiologically large shunt, which is a QP-QS of greater than 1.5 to 1, you can meet criteria for closure. And the strength of the indication is only based on functional impairment. But even without functional impairment, it's still recommended that these patients get closed. However, if you have elevated pulmonary pressures, it's still not a contraindication to close the shunt. And the challenge is that you have to be very careful because these patients can have challenges post-operatively. So with these patients, often you'll consider starting them on pulmonary hypertension therapy and looking at the response. And if they respond to the pulmonary hypertension therapy, then you can consider closing the shunt or doing a partial closure where you still limit the amount of shunting, but still allow for a little bit to go from as a pop-off valve. So she underwent closure and had a great success. But if we look at why do we close these atrial septal defects, the first is that survival is improved if we close it, but the benefit is typically significantly improved if we close it before age 24. And even between age 24 and 40, there's still improvement from a mortality standpoint for closing these, but the earlier the closure, the better. The other area is that we find with elevated systolic pressures, greater than 40 millimeters of mercury, also have evidence that those patients do worse if we close it after they get to that point. The cardiac complications following closure, the major is heart failure is the most common, especially if it's greater than 24 years old. And then the other major complication is strokes. So if we look at arrhythmias for this patient population, the data often is stated as that if you're over 40 by the time you close it, we're not getting a lot of benefit from closure for arrhythmia standpoint. The only challenge with this data is that we're looking at adults, and we look at time from surgery to then their follow-up. And so in this study, it looked at 5 years follow-up, but we're comparing 45-year-olds compared to 20-year-olds often. And so the 20-year-olds, it's really unclear what's going to happen long-term when they become 40s, 50s, and 60s. And we still don't have that data because we just haven't followed them long enough to know, will they have increased atrial fibrillation? But the data is starting to suggest that, yes, they are at increased risk, perhaps not as much as the later closures, but they still have increased risk. So if we look at atrial fibrillation and flutter based on age of operation at 30-year follow-ups, again, patients that are older definitely have increased atrial fibrillation and flutter, but even the younger patients, like I said, are having increased rates of atrial fibrillation at younger ages than we would normally expect in the general population. And a recent Danish cohort study found very similar evidence also. If we look at age over 40, it's still recommended that these patients do better if we do a surgical closure. But when you actually look at the sub-analysis of why do these patients do better long-term and have lower mortality, that's largely driven by recurrent pulmonary infections, and that's where the benefit comes for these patients, and unfortunately not as much in terms of pulmonary embolism or arrhythmic events or strokes. If we look at anticoagulation in for atrial fibrillation with congenital heart disease, the US guidelines do not take a stance on this, but the European guidelines have very consistently taken a stance saying all patients should have a standard CHADS-VAS score, and if you meet criteria, that's very clear-cut that they should be anticoagulated. However, they add in any patient with congenital heart disease who's had an intracardiac repair, and that can be a percutaneous repair or a surgical repair. They also recommend anticoagulation for any type of congenital heart disease, including atrial septal defects. And the reason is when we look at the data for many of the different lesions across any type of congenital heart disease, one of the major morbidities is stroke in these patients, and they tend to have strokes at lower ages. So if we wait to the point that they meet criteria for CHADS VAS score, we may have missed that opportunity to anticoagulate them and prevent some of the major morbidity and mortality associated with congenital heart disease. One of the largest and feared complications for atrial septal defects is Eisenmenger syndrome, where you get right to left shunting across the atrial septal defect. And this is an example of a 54-year-old woman who presented at her initial presentation with atrial fibrillation and class 3 to 4, New York Heart Association class 3 to 4 symptoms. She unfortunately declined all medical treatment, including other than rate-controlling medications, and she died 3 years after initially presenting. However, if you do consider a treatment for these patients, they really do better if you treat them for their pulmonary hypertension. Boston 10 is the best data for, and it's a class 1 indication, and so all these patients should be considered for that therapy. And there's increasing evidence that PD-5 inhibitors may also improve survival, although that's a class 2 indication, and there's an increasing, as in pulmonary hypertension, to do dual therapy up front, and people are starting to do that with this population also. The major thing is that ASD closure is absolutely contraindicated in these patients. And so at this point, you're really trying to do palliative measures. The other thing that's interesting is these patients still do significantly better than patients with pulmonary arterial hypertension, and their longevity and their morbidity and mortality is actually reduced compared to other patients with similar systolic PA pressures with pulmonary arterial hypertension, not from a shunt. So all patients with atrial septal defects really are recommended to have cardiology follow-up, even if their shunt is not closed. And the major thing is to watch for change in shunt size. So for patients that have a small shunt that is not thought to be physiologically significant, they can be spaced out to every 5 years for cardiology follow-up, with other patients being followed more closely. And the major things that you're watching for is atrial arrhythmias, a change in the shunt size, pulmonary hypertension, and heart failure. So in summary, atrial septal defects is one of the most common conditions to present in adulthood. Survival is reduced with late closure, and percutaneous closure is only acceptable for secundum ASDs that are amenable to closure. The major things that you need to watch for is atrial fibrillation, heart failure, and stroke are the most common complications with this defect. Our next case is a 45-year-old woman with long-standing hypertension that started during pregnancy, and she presented to her primary care clinic with dyspnea on exertion and atypical chest pain. So a chest x-ray was obtained, and what was notable is that she had rib notching on her chest x-ray, which interestingly had been on multiple prior chest x-rays also, but had never been picked up. So the radiologist picked this up and suggested that she may have coarctation of the aorta and recommended further imaging. She did get further imaging, and that shows she almost had aortic atresia with a very severe narrowing of her proximal descending aorta. In addition, she had a very extensive collateral network that allowed for blood to flow from her across that coarctation. Her echocardiogram was relatively unremarkable, and her imaging windows were challenging, especially at the suprasternal notch. But if you actually pulse that area, you did see evidence of the coarctation with a diastolic tail that you can see right here on her pulse wave Doppler, which is often associated with extensive collateral flow in these patients. So on further history, it turned out that she actually did have symptomatic claudication with walking, which wasn't surprising. She had a gradient of 40 millimeters of mercury from her upper extremities to her lower extremities and underwent a surgical repair with an interposition graft. Unfortunately, she's been subsequently lost to follow-up. So the most common condition with these patients, as in our patient, is hypertension, and the rate of hypertension increases with age. Because many of the complications that we'll go on over associated with coarctation of the aorta are secondary to hypertension, the guidelines have gotten far more aggressive in terms of the recommendations for management of hypertension in these patients. So all patients need your standard resting blood pressure monitoring that we would do in clinic with both upper and lower extremities, also to follow for recoarctation. But the other things that are added now are ambulatory monitoring, to make sure that outside of the clinic, they still have good blood pressure control, and then also exercise blood pressure monitoring, and treating any hypertension that's seen in any of these 3 areas is recommended. A UK cohort study found that in their population, only 18% of patients with coarctation of the aorta were appropriately treated for hypertension, so it's definitely an area that we can do better at. The reason to treat hypertension is that these patients do have reduced long-term survival compared to the general population, and many of these complications are thought to be secondary to hypertension. Heart failure that was thought to be secondary to a hypertensive cardiomyopathy was the most common reason that these patients died, but there was also dissections of both the ascending and descending aorta, and interestingly, post-op repairs for other non-coarctation cardiac repairs, which would include repair of a bicuspid aortic valve or the ascending aorta, these patients did not do very well post-operatively and had a much higher mortality than they would have necessarily expected. If we look at when the coarctation is repaired, patients that are older at the time of repair tend to do worse than patients with an earlier repair, which is a theme throughout this entire talk, that later repair is worse than earlier repair in patients with congenital heart disease. So the indications for intervention are a peak-to-peak gradient or a mean Doppler gradient of 20 millimeters of mercury from the upper extremities to the lower extremities, or that threshold can be reduced to 10 millimeters of mercury if you have decreased systolic function, aortic regurgitation, or any evidence of collateral flow like in our patient. The European guidelines have recently been published in 2020, this past fall, and they included also a 50% narrowing in patients with hypertension to also consider for repair, but that's not in the US guidelines. For these patients, they need close follow-up because reintervention is common, with up to 50% of patients needing a reintervention at their site of their coarctation. The patients that have the greatest risk of needing a reintervention are those with a surgical patch repair, but all patients still have complications regardless of the type of repair that is done. And the things that can be seen are aneurysms, pseudoaneurysms, recoarctation, or dissections for these patients. For adult patients, the preferred methodology is really doing a stenting, and this is not our patient that I presented, but a different patient here at Abbott who underwent a stenting of their coarctation and had a very nice result. And so the preferred method is stenting, and that's just because there's the lowest rate of complications of really across the board in terms of reobstruction and then also aortic wall injury. Just doing a balloon angioplasty of the coarctation has the highest rate of complications, and then surgery is in between. And most of the time we're now trying to not do that surgical patch repair since we know those have the highest rate of complications long term. If we look at the aortic valve in the ascending aorta, approximately 50% of patients will have a bicuspid aortic valve associated with their coarctation. And so these patients all need screening for a bicuspid aortic valve. And intervention on the aorta or the bicuspid valve is also very common, as we see in our other bicuspid valve patients, that it's just an isolated bicuspid valve. In addition, all bicuspid valves also need screening at least once for coarctation of the aorta. However, patients with isolated bicuspid valves, if you look at the total population, it's closer to 10% will have a coarctation of the aorta. The other major thing to screen for these patients is intracranial aneurysms. It's seen in about 10% of patients, and we still really are trying to figure out when to screen and how to screen these patients. So it is recommended to consider screening for these patients. It's often small, and our patient actually did have an intracranial aneurysm in her posterior circulation. Interestingly, when we look at the pediatric population, and they did screening in that age range, no one had a brain aneurysm that was seen. And they're often seen most commonly in patients with hypertension. So the timing of when to screen and if you should do serial screening is completely unknown, other than it can be considered in these patients at least once in their lifetime. And then the management of the aneurysms would just follow your standard management. So these patients require close long-term cardiology follow-up, and even for asymptomatic patients, the recommended follow-up is only letting them go for about 2 years if they have absolutely no symptoms. And so this is considered a moderate complexity lesion, but the actual follow-up is far more close than some of the other moderate complexity lesions, even if they're asymptomatic, just because the complications in terms of hypertension and then recoarctation are so common in these patients. So in summary, hypertension is very common in these patients and should be considered in all patients under 30 years old with hypertension. Stenting is preferred in the adult patients if at all possible, and you have to screen for bicuspid valves in these patients, and then also considering intracranial aneurysms, although we still don't know the appropriate timing of when to screen for these patients. Our next patient is a 41 asymptomatic-year-old man presenting to primary care. And when he came in, he had a heart rate of 147 beats per minute and was found to be in typical atrial flutter, but was relatively asymptomatic. So he was given a rate-controlling medication by his primary care doctor. He was started on apixaban and then referred to cardiology for further evaluation. His echocardiogram showed triatriatum sinister with an obstructive membrane. Interestingly, he had had 10 years earlier an echocardiogram, and this condition was present on it. The imaging was not as nice as this echocardiogram, but it was missed on his prior echocardiogram, but this time it was diagnosed when he presented. So coarctation sinister is a membrane across the left atrium that you can see in this picture. The key is with left-sided membranes, they're often associated with other forms of congenital heart disease. Mitral valve regurgitation is the most common other associated complication, but the other things that are important is atrial septal defects to screen for, and then anomalous pulmonary venous return. So to screen for these other defects, he got a cardiac CT scan, and he didn't have an ASD or VSD, but he did have an anomalous pulmonary venous return, which you can see right here in his cardiac CT scan. And again, you can see this membrane across his left atrium. The key is that pulmonary vein stenosis in these patients can also occur both prior to surgical correction or following surgical correction. So for patients with heart failure symptoms prior to or following surgery, it's important to look closely at the pulmonary veins to make sure that there's no pulmonary vein stenosis, as that's an easy thing to miss. So if you look at the clinical presentation in these patients, for the most common would be heart failure or atrial fibrillation in these patients, and those patients that have an obstructive lesion, pulmonary hypertension can also occur, and then strokes are another major complication, again, in this patient population. So our patient underwent an atrial flutter ablation, and following that, he had a surgical resection of the membrane, and then he had a Warden procedure. And what that is simply a method where you can take the anomalous pulmonary veins and baffle them over to the left atrium, and then the superior vena cava is attached to the right atrial appendage. And that was the surgical correction that he underwent. In follow-up for these patients, they tend to do quite well. Reobstruction or recurrence of that membrane is extremely rare in follow-up, and so the gradients tend to go down significantly, and they do well from at least that standpoint, with the caveat that if they have heart failure, it's often secondary to pulmonary vein stenosis. So in summary, this is a triatriatum sinister is a membrane creating obstruction in the left atrium, and the important thing is this is associated with other congenital defects. The most common complications for these patients are heart failure, pulmonary hypertension, strokes, and atrial fibrillation. Our next patient is a 32-year-old patient presenting to a primary care clinic for preoperative clearance for an orbital tumor. The primary care doctor heard a murmur on exam, and he also endorsed some worsening exercise tolerance. So because of that, his surgery was delayed for cardiac evaluation. An echocardiogram was the first thing that was obtained, and that was notable for severe right ventricular enlargement, some flattening of the septum, and then in addition, he had an elevated gradient at 57 millimeters of mercury for systolic RV hypertension and was diagnosed with pulmonary hypertension based on this echocardiogram. So because of that, he was referred to have a right heart catheterization to prove the diagnosis of pulmonary hypertension. And what they found is that he had elevated RV pressures, but his pulmonary arterial pressures were actually normal. So because of that, he had angiography of the pulmonary vasculature done, and what he had is branch pulmonary artery stenosis with severe dilation post-obstruction, and that was what was causing his RV hypertension. So branch pulmonary artery stenosis is a rare condition, but it can present in adulthood. And the main things to intervene upon are based on RV hypertension, progressive RV enlargement or decreasing function, and the distribution of pulmonary artery blood flow. A lot of these recommendations come from the literature of triatriatum of flow, and there's acknowledgement that these patients are likely different from those patients, but based on the lack of data, those are the recommendations that we follow. Restenosis in these patients is extremely common, and so they do need continued follow-up, as it's often that they need a re-intervention on these stents that are placed. The one thing that's interesting in this patient is he had an orbital tumor, and what we're finding is patients with congenital heart disease have an increased chance of getting cancer, which is very unfortunate, and we don't really fully understand it at this point. But their hazard ratio is about twofold, and that's come true across many different registries. So the Swedish cohort in Taiwan, Canada, and in California all showed very similar data. Initially, some people thought maybe this is just because they're getting extra CT scans and catheterizations in a child. But even if you take out those patients that had absolutely no ionizing radiation, there's still a twofold increase. And so we really don't understand it. And there's no one particular type of cancer. Pretty much all cancers, except for melanoma, have been shown to have an increased risk for these patients in terms of getting it. There's no difference in terms of screening for these patients that's recommended, but you do have to have an increased heightened awareness that this can occur. And it does also show the importance of good primary care for these patients, as that's often where it is found, but many of these patients do not have good primary care, unfortunately. So branch pulmonary artery stenosis. It's a very rare cause of RV hypertension. Intervention is based on symptoms, RV function, and RV dilation. Typically, they'll undergo stenting of the stenosis, and restenosis is very common, and because of that, these patients need continued follow-up. Our last case is a 36-year-old woman who had chest pain during exercise. Upon further history, it turned out at age 15 she had had syncope and was told that she did not need further evaluation. At age 26, she was told she had a murmur, and that was felt to be secondary to mitral valve prolapse, and no echocardiogram was recommended at that time. She did always feel in her 20s that she had poor exercise endurance compared to her friends, and no matter how hard she tried to train, it just didn't get better. And then she was training for a triathlon when she developed some chest tightness, and so she presented to the emergency department. An exercise EKG was obtained for her, and it was thought to be relatively normal, except her resting EKG, which I don't have that EKG, was consistent with a myocardial infarction. So because of that, they said you should get an outpatient echocardiogram. And I don't have her original echocardiogram, but a recent echo for her that we do have shows that she had congenitally corrected transposition of the great arteries. So she has a systemic right ventricle. She does have a mitral valve or a tricuspid valve that got replaced, and we'll come to that later. And then she has a left atrium. So we have the left atrium going across a tricuspid valve. The other thing for her is she had an Epstein-like tricuspid valve, so you can see the displacement here between her mitral valve and her tricuspid valve with a systemic right ventricle, and then her right atrium with a left ventricle that's subpulmonic. And so she's very typical in the patients. At the point she presented, she had a moderately reduced ejection fraction with an EF around 45%, and then the Epstein-like tricuspid valve. So the cardiac CT scan really nicely shows her anatomy, where again she has a right atrium going to a subpulmonic left ventricle going to the pulmonary arteries that are dilated. And then she has a left atrium that gets the pulmonary veins coming in, going to a systemic right ventricle connecting to the aorta. The other thing that you can often see in these patients is the aorta and the pulmonary artery are more parallel than normal. So this condition is from abnormal L-looping of the very primitive heart tube, and that's what allows then for this kind of more parallel aorta and pulmonary artery. Often there's other defects that are associated, especially a ventricular septal defect is very common in these patients, although our patient did not have that. The coronary arteries for these patients are typically a mirror image of the normal anatomy. And the important thing to remember is the coronary arteries follow their normal ventricle that they're associated with. So a systemic right ventricle is going to have a right coronary artery typically that supplies that ventricle And the challenge is a right coronary artery is not typically thought to be sufficient to really supply the blood supply for a systemic ventricle, and that very likely is the reason that so many of these patients do poorly long term. So for these patients, heart failure is almost universal if they live long enough. The age when they initially get heart failure is typically earlier if you have other associated cardiac abnormalities, where if you have just isolated congenitally corrected transposition, they tend to present a little bit later with our heart failure symptoms. And if you live long enough, unfortunately, they do develop moderate to severe RV dysfunction. So how do we treat heart failure in these patients? It's very controversial. So a systemic review failed to show any benefit with our conventional heart failure therapies, but it's hard to know what to make of this data. Unfortunately, it was severely underpowered, and if we combined 4 different studies that tried to look at it, we have a total of 187 patients. In addition, they had both D and L transposition of the arteries, which are likely 2 completely different syndromes that we've put into one study. In addition, they had 50% dropout rates. The inclusion criteria included people with a almost normal RV systolic function, which meant that it was very hard to show any benefit for any therapies, and the follow-up time was very short. They also had problems enrolling patients just because so many providers with the lack of data felt that it would be unethical to even try to do this study. So this study didn't show a benefit, but I think if most of our cardiology studies were based on this quality of data, we probably wouldn't have most of our cardiology treatments today. So it's hard to know what to do with these patients. If we look at follow-up, she was started on an ACE inhibitor and did have some initial improvement in her ejection fraction that later then kind of went back down to the mid-40s. In her late 30s, early 40s, she developed asymptomatic non-sustained ventricular tachycardia, atrial flutter, and then a Mobitz type 2 block that then progressed to complete heart block requiring a dual chamber pacemaker. So if we look at these patients, rhythm abnormalities are very common, and pacemakers are also common in these patients. In one study, they had up to 45% of patients having a pacemaker, although again, the study with 45% had a huge range in terms of ages from the 20s to 60s, and so as you get older, the likelihood that you're going to need a pacemaker increases dramatically. The thing that was the most troubling with this study was that 5 of their 39 patients in their series had sudden cardiac death as their initial presentation for a rhythm abnormality. And all of these patients, under further analysis, had only normal to mildly reduced RV function and really were asymptomatic prior to their presentation. And the theory that many people are starting to think about these patients is that they develop atrial arrhythmias, not ventricular arrhythmias, and that essentially their heart is beating so fast that the right coronary artery cannot supply enough blood flow, and that's why they develop sudden cardiac death. And that it's an atrial arrhythmia, not a ventricular arrhythmia, that may be leading to this etiology in these young patients. So in follow-up, she developed more moderate to severe tricuspid valve regurgitation and had worsening of her RV systolic function. And so because of that, she underwent a mosaic porcine bioprosthetic valve and unfortunately developed endocarditis during her initial hospital presentation. After recovering from that, at 6 months post-follow-up, she had increased gradients across her tricuspid valve, and so was started on warfarin with resolution of those gradients, and then again, after stopping warfarin, again had an increased gradient, and now is stuck with lifelong warfarin therapy. While we don't typically put mechanical valves with the right ventricle, these patients can be considered for a mechanical valve since they're treating it more like a systemic left ventricle than a right ventricle. But she didn't want to be on anticoagulation, although that unfortunately didn't work out for her. So for these patients, tricuspid regurgitation is extremely common. Up to 80% of patients have tricuspid regurgitation if they live long enough, with moderate or severe tricuspid regurgitation also being very common in this patient population. The survival for these patients is very poor if you wait to fix the tricuspid valve after the systemic RV falls less than 40%. So the 10-year mortality or transplant is very high for these patients. And so if you have a systemic RV that's less than 40% and they need surgery, the prognosis is poor and you can consider these patients instead for a cardiac transplant instead of fixing their valve. It's also poor if you have RV hypertension for these patients, and it's another poor prognostic factor. So the management for these patients is it's recommended that everybody just get a tricuspid valve replacement and not a repair. And part of this is because if you look at the data, patients tend to have TR following the repair, even with the most experienced surgeons. However, the overall data is with very small series of patients. The challenge with these valves is that they're often dysplastic and Epstein-like, and so most of the time patients just get a replacement. So these patients are very complex and they require close long-term follow-up. And even the patients that are completely asymptomatic, the longest you should let them not be seen by cardiology is about 12 months. And what you can see in this table is the amount of testing recommended for many of these patients is significantly more than most other patients. So getting routine echoes, EKGs, pulse oximetry, Holter monitoring on a routine basis, screening for atrial arrhythmias, since the morbidity is thought to be quite high once they develop atrial arrhythmias. MRIs to actually accurately quantify the systemic RV function, since that's often underestimated based on a transthoracic echocardiogram, and then exercise stress testing. So these patients require close follow-up with quite a bit of cardiac testing long term. So in conclusion, this is the most common complex congenital heart disease to present during adulthood. Heart failure in these patients is almost universal. Arrhythmias are extremely common, with the recommendation to be fairly aggressive with the management of the arrhythmias. And tricuspid valve regurgitation is extremely common, with the goal to try to correct it before their RV goes less than 40%. So in conclusion today, I've showed that congenital heart disease can present in adulthood. It's often first diagnosed with an echocardiogram. And the first presentation in adulthood typically is either an atrial arrhythmia or heart failure symptoms, typically in a young patient that you wouldn't expect to have it. These patients have increased mortality compared to the general population, no matter what condition you come. And so this figure shows at age 40, what would their actual, based on the different types of congenital heart disease conditions, would be an equivalent age. So for patients with an atrial septal defect, it's still just a little bit above the general population, whereas systemic RV is almost equivalent at age 40 to a 60-year-old in terms of their long-term mortality for these patients. One thing that we haven't talked about today is recurrence of congenital heart disease in patients' children. And it does exist, but it's significantly lower. So it's not universal, but it's often in the 3 to 7% range if you look across the different conditions. And we don't really understand why or what the genetics of these conditions are at this point, but we do know that there is an increased risk of recurrence. So because of that, it is recommended that these women go a fetal echocardiogram to screen for congenital heart disease if either parent has a history of congenital heart disease. Many of the OB doctors, especially in outlying communities, do not know this recommendation, and so it's one area that cardiology can be helpful if you're taking care of these patients, to let the women know that they do meet criteria for a fetal echocardiogram. And the same lesion does not necessarily occur. So we had one woman who had an atrial septal defect that she was followed and was doing relatively well, but she had a baby with a single ventricle. And so those can happen. It's very rare that you have that dramatic of a presentation, but that's why we offer the screening. These patients also have improved care if they're cared for at a comprehensive adult congenital program that offers the services to take care of these patients, and then also really is up to date on the overall guidelines of how to care for these patients. And so they looked at this in a Canadian cohort, and in Canada they found that the patients cared for at a referral center did significantly better than patients that were followed either in a mixed setting or just in a general cardiology setting that only saw rare patients with congenital heart disease. So hopefully today I've shown you that congenital heart disease is a lifelong condition, and regardless of the different types of defects, these patients need long-term monitoring and care to try to minimize the effects of the morbidity and mortality that can be associated with congenital heart disease. And with that, I'll open it up to questions.
Christina?
Yeah.
If I understand what you had mentioned earlier, so if I have a 40-year-old male who has atrial fibrillation and a previous percutaneous atrial septal defect repair, they should be anticoagulated.
Correct. The European guidelines would support that you should consider anticoagulating them. The US guidelines, like I said, don't take any stance on this, but I think more and more people are considering anticoagulating these patients because the morbidity and mortality with atrial septal defects is still increased compared to the general population, and so their likelihood of having a stroke for some reason is increased that we don't completely understand, and so you can consider anticoagulating those patients.
That was very good. Thank you for that.
Yeah.
I love the imaging and the stories. Do you have any sense in the population that we're following, what % of the patients are diagnosed as adults versus children? And in the adults, I assume it would be bicuspid aortic valve. After that, what do you see?
So we don't actually have great data on that, and I don't know that we even have data at our own institution of what rate are we seeing patients presenting in adulthood. But if you look at the Korean study, all of the different conditions that we saw, I could have selected as examples of patients that we talked about. So I took care of a patent ductus arteriosus and cardiac MRI on Friday that actually probably needs closure, and that presented in adulthood. We have examples of ventricular septal defects. We have examples of lots of atrial septal defects is probably the most common. Occasionally pulmonary stenosis, although many of those patients with pulmonary stenosis are diagnosed earlier just because someone hears a murmur. So really, you have to get through a lot of medical appointments with absolutely no unusual murmur to adulthood, and so often it's the patients that have worse medical care if you have a stenotic lesion that doesn't get diagnosed earlier. We have Epstein-like valves that have gotten diagnosed in adulthood. Congenitally corrected, we have a few patients in terms of adulthood. It's a more rare condition, but we have a couple of those patients. So pretty much all the different examples that I gave, we have multiple of those examples. Coarctation of the aorta, we have quite a few different examples of those patients. And then also patients that have been followed for a long time with a bicuspid valve that nobody thought to look for a coarctation, and then it's diagnosed, often with the ambulatory or blood pressure monitoring. So that's probably an area that's probably underdiagnosed in our patient cohort. But again, we don't have great data in terms of what are we missing. Yeah.
Great talk. Was that Warden Baffle the same warden that trained at the U with Lillahai?
Correct.
Herb? Okay.
Yep.
Yeah, just as a son, I went to school with his daughter. So.
Very cool. Yeah.
Just have one online comment thus far. It's from Dr. Hahn, who says, great talk and congratulations on being accepted to the University of Michigan Adult Congenital Heart Disease Program, and that you will make great contributions to the field.
Thank you.
Thank you.
All right. Thank you.